Namaskar, this is Dr. Sanjay Kumar Rai, and this video is to share my experience of MCPS clinical exam with my colleagues who are seeking for MCPS. Recently I have this session, that is the 2023 July session, I have faced the clinical of MCPS exam under BCPS, and with the blessing of Almighty Ishwar, I have passed the MCPS exam. And I am going to share my experience with my colleagues who are asking me my experience of this clinical exam of MCPS. So you know, the MCPS exam has three components. Clinical exam, at first the written with the qualifying the written exam of MCPS, then you will go for the clinical and viva. Clinical has two components, long case and short case. Okay, long case and short case, and then viva. My center was the Shohid Sohrawardi Medical College Hospital, where the long case and short case was taken, and the viva always in the main building of BCPS, that is the Mohakhali. So now I am going to at first, in the morning of the exam, it was started just 9 AM. At the very beginning of the exam, the teachers panel, that is the examiner panel, there were 4 examiner or professor. One of them, who are the convener of that center, briefly the examination procedure. At first the long case, then short case, then viva. At first our exam was started with the long case, and the long case was distributed with lottery, and I am sharing my experience of long case. At first I would like to say that I am nothing exaggerating anything else regarding my long case, but it is true that my long case was very much complicated. But I think also that if your case is complicated, that means there are so many findings. You may miss some finding, but you will find out many more findings. So as much as the finding you will find out, this will be blessing for you. So my long case has 3 components actually. Number one, diabetes and its complication, and number 2, rheumatoid arthritis and its complication, and number 3, bronchial asthma, that is the asthma with its respiratory tract infection. Actually the 65 years female diabetic and hypertensive got admitted to hospital with the complaint of single complaint, that is fever with cough for the last 7 days. Actually this fever and cough due to respiratory tract infection. Okay, so now I will go for the other component of the diagnosis. So at first the diabetes mellitus, actually the main diagnosis is the diabetes mellitus and its complication with its and others components. Okay, so what are the other complication of diabetes mellitus present in my case? Diabetes mellitus, actually the patient diabetic mellitus with hypertension, with retinopathy. My patient has the combination of the combined diabetic and hypertensive retinopathy. So I mean D plus H. I'll elaborate later regarding the diabetic and hypertensive retinopathy, with diabetic nephropathy, with diabetic autonomic neuropathy, with diabetic peripheral neuropathy, and with ischemic heart disease, with peripheral vascular disease, and with the rheumatoid arthritis, with joint deformity, with DPLD, okay, joint deformity, DPLD, with iatrogenic Cushing syndrome, and last one, the bronchial asthma with rheumatoid, RTI, respiratory tract infection. There are 2 teachers to take the long case. The first teacher just cross the diagnosis. Each and every point in your diagnosis will be crossed by the teacher. And the second teacher asked me regarding the investigation, treatment and other associated in question he asked me. So the first teacher crossed me for the diagnosis each and every component of diabetes mellitus. So at first the diabetes mellitus, its duration around 25 years, and initial treatment, present treatment, insulin dose, other oral hypoglycemic agent, and any history of hypoglycemic or hyperglycemic episode. Okay, any other associated condition with diabetes mellitus, any history of surgery, any blood transfusion, etc. Then retinopathy. They ask me, why are you saying the diabetic and hypertensive retinopathy? That means what are the evidence? The patient actually has the many more finding in the on fundoscope on both eye. Regarding the diabetic retinopathy, patient has the hard exudate and dot and blood hemorrhage on both sides. And the evidence of hypertensive retinopathy, patient has the silver wiring, AV nipping, and on most probably on the right eye, patient had the flame hemorrhage. Okay, so this is the features. These are the features of the diabetic and hypertensive retinopathy patient had. And then the diabetic nephropathy, evidenced by the bedside urine examination, which show the dipstick test positive for proteinuria, that is 2+. Then diabetic autoimmune neuropathy. Why? That as because in history patient give the history of early satiety and nocturnal diarrhea, and also alteration of bowel habits, sometimes diarrhea and sometimes constipation. And most importantly, patient has the nocturnal diarrhea. And then the features of peripheral diabetic peripheral neuropathy, also in the history, as patients give the history of burning sensation, and on the examination patient has the sensory impairment in the form of Glove and Stocking pattern. And ischemic heart disease, as because patient give the typical history of chest pain on exertion and relief by taking rest, and she was put one sublingual nitroglycerin spray for the last 5 years around. And peripheral vascular disease, because the patient gives typical history. I ask this patient, I give this history to my teachers with confidently that the patient gives typical history of vascular claudication. Okay. Next component is the rheumatoid arthritis, its duration, treatment, improvement, that is the disease activity score, DAI, disease activity index. Patient was initially given methotrexate for the last around 5 years. And then a joint deformity involving all the involving both hand and feet. And patient has the jet deformity, Bartonella deformity, swan neck deformity, and ulnar deviation also. And patient has the DFLD, evidenced by AN inhibited fine inhibited crackles not altered by coughing. And patient also has features of iatrogenic Cushing syndrome, evidenced by a thin skin, but there is no easy bruising. But patient has the typical features of proximal myopathy. And asthma. She was treated for asthma over the last around 10 years, and for that she was put one inhaler and other medication. The name the patient could not mention properly, and a respiratory tract infection. So this is the long case. And subsequently the second examiner asked me regarding the investigation and treatment. Interestingly, the patient has the features of asthma and DFLD. The second teacher asked me these 2 points and want to elaborate these 2 points: asthma, obstructive lung disease, and DFLD is a restrictive lung disease. How to investigate? I said that lung function test in the form of spirometry with DLCO and HRCT, and 6-minute walk test. These 3, and then the subsequent question were regarding the treatment and follow-up, mostly regarding the diabetes mellitus and rheumatoid arthritis. the biologics agent what can be used in the treatment of rheumatoid arthritis, and structure. Very easy question that are. Now the short case. My first short case was an older male patient around 60 plus age. My instruction was just palpate the abdomen. Just palpate the abdomen. One palpation of the abdomen, there is multiple nodular structure, nodular lesion in the abdomen, center of the abdomen. What is your impression? It's a nodular lesion in the intra-abdominal lesion. What might be diagnosis? Sir, lymphadenopathy. What is the cause of this lymphadenopathy? Most probably lymphoma. Most probably non-Hodgkin's lymphoma. Why are you saying that this is non-Hodgkin's lymphoma? As because this is older age and both the testicle are enlarged. As because I already examined the patient for genitalia as the component of palpation. So both the testicles are hugely large, around as the tennis ball. The two testicles becomes hugely large. Okay, so it's the first case. And the second case, young girl around less than 20 years who are sitting in position, and instruction was just look at the face and do the relevant. Okay, so I just look at the the face. The face was pale and puffy, not periorbital swelling, just puffy, pale, and both the leaves are dark in color. That is the cyanosed. And I look at the finger, and there is clubbing. Okay, is clubbing. As the component of relevant, I examine the patient for features of central cyanosis plus peripheral cyanosis, all the site of peripheral cyanosis, and the clubbing. Just acting to see the clubbing. Though there is a obvious clubbing, but in the presence of that obvious clubbing, I went for to examine the patient for Shamrock window test and fluctuation test and etc. After completion of this procedure, I asked the patient to lay down and go for a precordium. As the time was very short, my time was very short, around 2 to 3 minutes. So I just auscultated the patient, auscultated the precordium, and there were wide and fixed splitting of the second heart sound, and there is a soft systolic murmur in the pulmonary area. So with this finding, I made my diagnosis. After this examination of the precordium, I went for the back of the chest with sitting position for any features of bronchiectasis in the form of coarse crepitation altered by coughing, but there is no crepitation, So after this completion of this examination of the relevant and finger, precordium, and then chest, I already also missed in this station as because I did not examine the patient for JVP or leg edema, and they criticized me. However, after completion of the examination, the teachers asked me, what is your impression? My impression is central cyanosis with the precordial finding already I mentioned, and lung base clear. So what is your diagnosis? The diagnosis so left to right shunt, most probably ASD with reversal of shunt. This is Eisenmenger syndrome. Why are you saying that it is Eisenmenger syndrome? As because the patient has the features of central sinus and clubbing and so on, etc. How will you investigate? How will you treat? etc. Okay, you know. Now the number 3 case, very interesting. Around 50 years at a female patient who is on lying position. My instruction was just examine the patient for sensory impairment, sensory modality. Okay, so I did just find us in the by cotton and pain by pinprick. Patient had the definitive sensory impairment with the sensory level around at the level of xiphoid sternum. Actually, the upper limb was very much confusing around xiphoid sternum and just below the xiphoid sternum. I said the upper limit of sensory impairment is T5 or T6. I'm sorry, T4. I think I said the T5 or T6. Okay. T5 or T6 dermatomal distribution, and the most likely the lesion of vertebral lesion sorry, the level of vertebral lesion is T4 to T5, the 1 to 2 segment above the dermatomal distribution, dermatomal level. Okay, then the teachers asked me what is your impression. Okay, so I said that there is a dorsal myelopathy which may be due to compressive or non-compressive. Dorsal myelopathy, compressive or non-compressive with catheter in situ, as because there was catheter in situ. What might be the cause of this dorsal myelopathy? So compressive, non-compressive. What may be the cause of compressive myelopathy? Compressive myelopathy is just I said TB, tumor, and trauma. And what might be the cause of non-compressive? I said the ATM and multiple sclerosis. Then they asked me how will you investigate. Okay. Oh yes, before that they asked me do you want to examine what others relevant do you want to examine. Actually I asked the patient, when they asked me what is your impression, what is your diagnosis, then I asked them for to see the relevant, what relevant I want to examine. They asked me, then I say that the vertebral column, no, sorry, spinal cord, sorry, vertebral. I want to examine the patient for a spine, upper limb, and a cranial nerve, and also fundoscope. Then the one teacher and the examiner asked me what relevant, what finding do you expect on fundal examination. So I said that if it is TB, then tubercle. If it is a multiple sclerosis, the optic neuritis or optic atrophy in a long-standing case, and etc. Okay, so this is all about the third case. And the fourth case was a little bit easier. I should not say that. Okay, older male patient who was in sitting position. The instruction was just percuss and auscultate the back from the auscultate the chest from the back. On percussion, there is percussion of dal on the right side. Okay, just on the right side, just below the external angle to downwards. And on auscultation, there is a bronchial breath sound. Breath sound was bronchial, and the coarse crepitation followed by coughing, and vocal resonance was increased. So at this time my bell was given and time out, but the teacher allow me and they asked me what is your diagnosis. I want to see the relevant, but they did not allow me to see the relevant. Just asked me to give your diagnosis. So I put differential diagnosis as the pneumonia with a consolidation phase, resolution stage, and localized bronchiectasis maybe, and fibrosis. I did not know. I don't know. Okay, I say give two diagnoses. Number one is pneumonic consolidation with resolution stage and bronchiectasis. Okay. And the second teacher, most probably the second teacher, asked me, okay, doctor, you are treating this patient with appropriate antibiotic as for pneumonic consolidation, what already you said, but at the follow-up around 2 weeks after, the patient is not improved by clinically and radiologically. Then what will you do? Yeah, I will say that I said that as the patient is older and not improving after appropriate antibiotic 2 weeks, after 2 weeks, then I will go then this case might be associated with underlying malignancy. So to evaluate, further evaluation, I will do CT cyst of this patient and sputum for gram staining, AFB staining, gene expert, and malignant cell, sputum for malignant cell most importantly. And if patient has the features of pleural effusion, any effusion, the aspiration, and study for gram staining, culture sensitivity, AFB staining, gene expert, structure, but most importantly serological examination of malignant cell plus ADA and okay. So with this my clinical examination was done, and then we were carried out, we were transported to the BCPS venue by PCPS car, and the examination was viva was started just 2:30 p.m. And it was a very horrible experience, I think, as because the viva was 18 minutes and 18 minutes, or that means two board 18 minutes and 18 minutes, every t-shirts for 9 minutes and 9 minutes, 9 minutes and 9 minutes, and the each and every chapter of Davidson were crossed by this 4 t-shirt. However, it is very difficult to attain this type of viva after completion of short case and long case clinical examination. However, around 8 p.m. the result was published. Unfortunately, I have passed. So this is all about my experience to share with my colleague. If you any query, any question, please comment on this below of this video, and that will enlighten me also, as because I am also a student of I am also a candidate for the MCPS for the next session. So please pray for me. Thank you very much.